welcome to this session on cognition, learning, and behaviors in Batten disease. We really want to focus on the practical guidance that we can give you in the realm of cognition and behavior. Our disclosures here are that at our center in Denver, we do have support from 2 family foundations, but I don't believe that that creates a bias in the information that I will present to you this morning. So there are some generalities that we can make, say, across Batten disease broadly, kind of all types, but I think hopefully most of the parents in the room will be familiar with the fact that depending on what type of Batten disease your child may have, the order of events and the age at which symptoms begin to emerge and then the pace at which the symptoms progress is variable. And so, you can sort of make generalities even more specific to CLN1 type, 2 type, 3 type, et cetera. That order of progression, so what starts first? Is it vision loss? Is it speech decline? Is it more motor decline? That also is not the same. And that's really interesting across the Batten diseases, right? That there's variability in the order of events. But with those caveats said, we would anticipate cognitive decline as a hallmark feature of all of the NCL types. I need to keep an eye on that monitor too. So the prior data that we can turn to there aren't a super huge number of papers, but there are some excellent papers that are the product of research done by folks who are here at this very conference. And so what I'm showing here is a short summary from work done by Dr. Heather Adams and Dr. John Mink in Rochester, where they measured cognitive abilities of children with Batten disease. So this study was done in CLN3 type patients. First part that they did was sort of a pilot study that was way back in 2003, where they looked at 15 patients with CLN3 with an average age of 14, the youngest being almost 9, about half and half, girls and boys. What they found basically in that pilot was that attention, so the child's ability to have sustained attention, was significantly below average for their age. This was measured by doing kind of number recall testing, remembering digits forward, repeating back those digits backwards, which is a test of memory and learning. So they then expanded to a longer longitudinal study, which went on for several years and included 18 patients in total. 5 of whom were able to have at least 2 assessments during the course of the trial. And basically what they found were significant impacts on auditory attention, memory, estimated verbal intellectual function, and verbal fluency. And so just to break all that down, I don't think it's going to be a surprise, but we can say there are specific aspects of cognition, specifically in the domains of verbal fluency, speech generation, and memory and attention that are going to be impacted. There was, interestingly, in their study, no significant difference in these measures between boys and girls. Although we just heard that there, in the long arc of the life course, there may be some differences in speed of progression. But in this study, at least, the cognitive measures were the same between boys and girls. But they were worse in those children who had had seizures. So seizure is sort of a negative predictor for cognitive progress or pace of decline. This is just a graphic from, there we go, a little graphic from that paper from 2007 showing the, so if the top line going across the very top there at 0 is what we would expect of average performance in these domains of left to right vocabulary, sentence repetition, story memory, digit span, and verbal fluency. So if all those are kind of the specific things that they were testing and measuring, all of the children really are performing well below average. So about 2 standard deviations below average with the error bars shown there for each. And then a separate graphic that they also showed, this is sort of demonstrating the pace of progression over the time. And so the axis along the bottom there is showing you how long has the child been since diagnosis in years. So from 2 years since diagnosis to up to 12 years since diagnosis, how did their vocabulary scores change? And we can see that there is a decline over the years. Separately, for CLN2 type patients, Dr. Nickel and the team out in Germany have published data that were obtained on CLN2 patients prior to the introduction of Brineura. So these data are sort of truly the natural history of CLN2 type. And in summary, I would say patients with CLN2 disease have a rapid decline in clinical function over a 2 to 3 year time course from the onset of first symptoms, such that most will have a complete functional loss within about 2 to 5 years. Specifically, the declines are rapid in motor and language scores. And this paper sort of is a more generalized paper. It's sort of tried to address all of the CLN types in one paper. But Dr. Simonotti and Dr. Williams in 2022, so just 2 years ago, published this great summary, which really just tells us that the developmental trajectory early on in the disease will just start to slow, right? So we expect that when children are developing, that they would be in a constant state of gaining new skills, gaining new language, gaining more complex abilities to understand social interactions. As we go through school, things get more complex. But the ability of children with Batten disease begins to sort of show plateauing of gaining of new skills, and then ultimately a decline in those skills over the time. I'm going to hand over now to Dr. Miele from our center to speak about the impacts on education that these cognitive realities create for our children, and how best to handle them.
Thank you. Okay, yeah, so given what we know about changing abilities in the domains of memory, attention, language, how do we create the best environment for our kiddos at school? So that's what I kind of want to talk about. So I am a pediatric neuropsychologist. If you're not sure if your child has been seen by a neuropsychologist or if it's right for you, please come talk to me, because the answer is yes. But I realize that might not be offered at every center, or there just could be some confusion about who does what. So please come talk to me. Anyway. Okay, so just to kind of set the stage, thank you, Dr. Santucci. So we know that children with Batten disease have a very different learning curve, even when we think about other kids with severe disabilities. And so these kids require continuously adapted education. Hopefully everyone in this room knows what an IEP is. If you don't know what that is either, please come talk to me. This is a document that the school creates and is often modified on a triennial basis, which means like every 3 years. But for this population, we feel that that is very inappropriate, and this document needs to be able to be modified kind of yearly at a minimum. So in the IEP, there are these goals, which we'll talk more about, but the goals also are going to need to be able to be adjusted because they need to be, I think, continuously evaluated to ask or answer the question, are they providing appropriate and meaningful challenges given kind of where a child's cognitive, motivational, and language abilities are? In the IEP, we want accommodations or modifications in the areas of vision, motor, cognition, memory, and language. And so I just tried to kind of break out kind of an overall educational arc here. In the early years, we want the teaching and the learning strategies to kind of avoid problems, but really utilize the strengths of your children. In the middle years, there's a little bit of a shift, and we need to kind of change from increasing knowledge to kind of maintaining current knowledge. But then overarching throughout all of the years, the social setting that can be provided in an academic environment, given some caveats, but in general, the social setting at the school is really kind of an important continuity over the years. This can kind of promote education, especially if the schoolmates kind of know the child before symptoms become apparent. There's multiple touch points during the day where these social experiences can happen. In the morning, teamwork, breaks, art, music. There is some data that talks about how attending to music can help with orientation, to actually refresh memories, improve cognition and mood in individuals with dementia. So I don't know if this has been systematically studied in kids with Batten disease, but it certainly seems like some things that I've heard. Anything as we've talked about in the prior session, anything that can kind of delay some of these cognitive changes. If it's something like listening to music, we can do that. We can do that. Okay, so I'm talking about the IEP here. So the IEP should be put in place immediately after receiving diagnosis. This should not be a document that we wait to form until we have kind of difficulties. It should be formed immediately. There's some recommendations that an evaluation of vision should also occur kind of with construction of that IEP so that that domain is already accounted for. And then we're trying to set these goals. And so to me, like the goals mean what your kiddo is going to be doing throughout the course of the day. So if you don't have very many goals, or the goals aren't specific, or the goals are not appropriate, like your kiddo's day is not going to be a good one. So here I just sort of list out goals should be realistic and achievable, but also concrete and well described. So this one I think can be challenging for schools because we need to be, the goal needs to be specific so we know what we're doing, but not so kind of inflexible that there's not kind of room for leeway. So they need to be dynamic adjustable. And then kind of also change, in the middle years, maybe changing from more traditional academic activities to more daily living skills. But the focus should just be on activity and involvement, not isolative rest. So this is something that I kind of want to highlight because I think that while each child is, might have individual needs in terms of, needing a nap or rest at school, which we want to accommodate for, they should not just be, alone in some room or with one teacher. Like we want them with their peers, with support, paraprofessional support, so that they're continuously stimulated in those ways. And so that's why this document, the paper that I pulled these recommendations from, really talks about the IEP not being only individualized for the student, but to also talk about how the whole school is going to kind of support the student during like moments where the entire school is together. And so I like that kind of broad view for our kids. This slide is busy. It has some educational strategies, and I'm happy to talk with people more if they want to know more about any of the lines. The ones that I have highlighted are the ones that kind of spoke to me. So project work is one way to help our kids kind of stay interested in school. And what this means is to pick a topic that they're already interested in and have that be what they're working on. So it could be any sort of interest that the school kind of broadens upon. I like this refreshing memories idea. So to activate and elaborate old memories, because again, this could improve cognition and mood and delay the fading of other memories. So constantly kind of having kids remember their memories. Supporting communication also is very important. And I thought this note was interesting that even though some other skills we're concerned that they will be declining, that receptive vocabulary, so this means kind of what kids can understand, could still be gaining actually, even though other skills are starting to decline. So that's even more important why we are still, talking to our kids and helping them understand, more things. Utilizing tools that support functions. And I kind of toyed with the idea of putting AAC device on here or not, because obviously we need to be able to see the AAC device to be able to use it. However, in our clinic, our speech therapist does talk about how there are buttons and switches that kids can use to operate an AAC. I also like the fact that in our clinic, we talk about voice banking. And so the AAC can respond in your child's voice when it speaks. And so even though there might be a time and a place for an AAC device, I still feel like using it in that moment kind of could be rewarding for the child. And then the last one, I had to pause when I read it because I thought, wow, this is exactly what I do. So we probably need to work on that. So inform instead of asking or controlling. And so what this is talking about is that when kids have cognitive difficulties, there's and sort of reduced expressive language, there's the tendency for the person talking to them to just like pelt them with questions like, how are you today? What did you have for breakfast? How are you feeling? What do you want to do? Like all these questions. And so for a person with cognitive difficulties, that can actually create a lot of increased anxiety and frustration, and uh, can can kind of lead to being stuck in this anxiety state, which is like not what we want. So I think there's also an importance of balancing this, informing, like, here we are at the dinner table, and again, here are your 3 options for dinner, or, just a little bit less questions and more kind of informing. And so that might be something that occurs over, again, the educational arc, but I thought it was important to talk about today. So this slide I'm going to skip over also in the interest of time, because you're going to hear about that later from another one of our speakers. But to just introduce it now, that since we're talking about supporting behavior, there's something called a functional behavioral analysis that the school can complete that is one of the direct lines to be able to work on behavior at school. But that's all I'll say about that. And so just kind of the last plug here, because it's a team effort, right? So we want the school to pony up and meet our kids where they are and provide them with the supports they're legally required to provide. But at the same time, we really need to support the school. They might not know what Batten disease is. They might have never had a kiddo with this. So expecting them to just kind of have all the answers immediately, I think, is unfair. And so something that I recommend in my reports is that the school actually provides the teachers with time to learn about Batten disease, whether that's watching something like this or coming to something like this. They need time to learn about it. And obviously they're hearing from parents, but sometimes what I hear from my families is that the school listens to parents, but they really want to hear from the medical people too, which I think is unfair, but I can kind of understand their perspective. So so the role that hopefully your multidisciplinary team or at your center of excellence or your hospital can really kind of interface with the school to help them learn kind of what they need to know, so that, again, we're talking about this long educational arc. We want kids in school as long as possible. And in order to do that, they really need to know what they're dealing with. So we just need to remember to support our teachers. And with that, I'm going to turn it back over.
To our little do-si-do. So what we've noticed, of course, is that, we're giving this talk about cognition, learning, and behaviors. And I think the reason to put those all 3 into one talk is that these things are very intricately linked, right? Like the child's ability to take on new learning at school or participate in school is directly linked to their cognitive abilities and status. And behaviors, as problematic behaviors may emerge, is due to the cognitive decline rate. So when trying to address symptoms, though, and help kids have an easier time with their families or attending at school, I'd say we've noticed that in CLN2 patients, attention deficit type symptoms are present really from the preschool years and onward. And like for any child who has an attention deficit hyperactivity disorder diagnosis, some of the medicines that we would use in other diagnoses, like just routine ADHD, can be helpful for the attention deficit that's present in CLN2 or CLN3 patients. Specifically, guanfacine and clonidine are 2 non-stimulant medicines that I've found can be helpful, with the note to clonidine that it also is helpful for initiating and maintaining sleep, which is necessary. And just to say that those multimodal therapy interventions are just critical from the moment of diagnosis, PT and OT and speech, to help guide the child and guide their family about how best to support them. And then in CLN3, where we're treating 9 patients at our center, I'd say most significant or most problematic are those mood and dysregulation symptoms that tend to arise kind of with the onset of adolescence. We know that adolescence generally has its onset at around age 10 or 11 for girls, and maybe a year or 2 behind that for boys. But just puberty, man, puberty in the face of cognitive decline is difficult to manage. And I would say medicines that address mood stability and specifically SSRIs or atypical antipsychotic medications are those classes that we found to be particularly helpful. So at this point, I'm going to stop talking and let you hear from a real expert on Batten disease and its impact on cognition and behavior. Beth Fries is a parent of two daughters with CLN3, who's going to share about their experience in the realm of managing emotional regulation and behaviors.
Thank you. Thank you. So as Dr. Santucci said, I'm Beth Fries. We're throwing laptops, behavioral issues. We're okay. We have meds and therapies for this. It's okay. So I have two daughters, Cecilia and Lily. We have five daughters, but Cecilia and Lily have CLN3. Lily has always been our gentle flower, easygoing. She has had some anxiety and cognition, which has mostly resulted in like sadness for her. But Cecilia has always been a force. And so we're going to talk about her because she's much more interesting. I'm just gonna put my big asterisk disclaimer on this that nothing I'm about to say is scientifically founded. It is our experience only, and it reflects our family and our experience with her. So I'm going to show you some graphs that I made based on these behavioral skills and anxiety scales where 1 is like a normal human being and 10, we are dropping them off with a sticky note on their forehead to the psych ward, like we're done. And anxiety is we're good, and 10 is again, we can't do you anymore. So to kind of give you an idea as you're looking at this slide, I'm going to kind of run through Cecilia's progression, if you will. We noticed behavior with her looking back from an infant. She didn't sleep well. By age 2, she was headbanging because she couldn't speak. She was biting kids in preschool. She was never able to organize her environment, like put toys away and understood what that meant. She was unable to learn basic skills in kindergarten and was having behavioral issues like hiding under desks and biting off pencil erasers. By 6, when she started to lose her vision, she was diagnosed with a sensory processing disorder. And we went to some intensive OT that taught us about her need for heavy work or proprioceptive input. And her mood was big and angry all of the time, which would mean tantrums for over an hour, 2 to 3 times a month at this point. And she was like an on-off switch. So she was either like 110% going strong or she was asleep, which was nice sometimes. And we also had, this is like age 6 to 8, and we got diagnosis at about 8.5, but we started to notice the perseveration on all the topics starting at this time too. 8.5 at diagnosis, we finally got some answers as to why our child was having these big behaviors and why she couldn't learn things. And then it gave us permission also to try medications. And so we were then able to really see this relationship between anxiety and behavior with her. And it was logical. Like if you were losing your vision and your ability to be around your environment, you would need some help with anxiety as well. And we had this realization that her major behavioral problems were because she didn't have the cognition to really learn those tools like normal kids to deal with those big emotions that she was having. By age 9, we were having physical aggression, kicking, throwing, pinching, scratching, biting, hitting, slamming, holes in walls, doors, all of that. And that's when we were introduced to ABA therapy. And I'll talk a little bit more about that. By 11.5, her behaviors and anxiety were still increasing, and we were right on the verge of puberty then and menstruation. And at this point, ABA was really no longer proving effective because her cognition again had declined. And so as parents, though, we finally had some tools from ABA to help us like survive this phase. And we also increased medications pretty heavily at this point to help. We increased frequency and dosage a lot. By 13, we were pretty much at our wit's end. She was a beast. She was angry all the time. It was sad to watch your child just be angry, like she was not well. She was having storms or tantrums almost daily. School was having major behavioral issues with her. And at this point, we were able to try some new medications under a palliative plan, if you will. And I'll talk about that in a minute. Last summer, when she was 14, we kind of hit our peak. Like her anxiety was off the charts. We kind of have talked about her cycle of perseveration topics in the past as like a Ferris wheel. Like we're talking about pets today, we're talking about holidays, we're talking about birthdays, we're talking about dolls. And last summer it became like Wheel of Fortune, like zing, and we're talking about all of them at the same time for a long time. And again, the behavioral and the physical behavior intensified, and we like maxed some of her doses and we added more meds. And I will say now, since January or so, her cognition again has declined this year pretty significantly. And she now no longer has the energy, the mental capacity really to have those big angry outbursts. She doesn't have the endurance to have a tantrum for more than a few minutes even. Her behaviors are mild at this point, which is a blessing, but it's also, just Batten taking a new form, which unfortunately is what we know the end to be. But because of that, we were able to start weaning her off some meds. And we haven't given a rescue behavioral med in probably over 6 months. So this chart just kind of shows the different colors of lines. You can see them there: cognitive decline, physical and anxiety increase. If we go to the next slide, maybe. Yep. Okay, there it is. So I mentioned ABA therapy. We've tried all of these therapies over the last several years. PT, OT speech, of course, the intensive OT. And then when we got ABA at around age 9, that's when everything kind of started to shift. At this point we were starting to take this parenting aspect of not being able to parent our child personally. And ABA really taught us to create that break in our brain, because it taught us how to handle her appropriately and set a physical and emotional boundary of like, this is not a reflection on me as a parent or on my child. And so I'm going to walk through these pictures. We happen to have a photographer at our house this day, and this could have been any day at this point in time. Cecilia was doing a preferred activity and it was time to get ready for dinner. Lily was going to set the table and Cecilia took out all of her anger of having to stop her preferred activity and lunged across the table. And it took my husband and we learned skills through ABA to how to physically remove her safely from the environment. By physically picking her up, but how to do that safely so we wouldn't hurt ourselves or her. And we locked her in her room because we needed a safe physical boundary between her and us. And as weird as this might seem to normal, like I wouldn't show this to normal families because they don't get it, but for our kids, like some of them need this physical space, and ABA gave us those tools to be able to do that. One of the huge benefits about ABA was that these therapists are willing to put in the time with your kid to really get to know them and what makes them tick, and finding the right therapy team that is able to know what the disease is and to maintain those goals is huge. Let's see here. So by 11 and a half, like I said, we had the tools finally, even though it wasn't necessarily beneficial for her because cognition had declined. I'm going to talk a little bit about her medications, again, with the gigantic asterisks that this is our care plan for her and that we have come up with this plan, some of this under palliative with our doctors. And ketamine is on there, and I'm just going to say, like, this is medication that is not typically available, and a lot of child psychiatrists won't use routinely, and it may not be easily available in your location. I will say that ketamine was the game changer for us. Just to back up though, you can kind of see the increase in meds as the anxiety and behaviors increased. 2 of these are in there for sleep, so trazodone and Seroquel. And I will say, like, if your kids are not sleeping, as you know, like that adds to all of the anxiety and cognitive issues. So getting the right sleep meds on board is huge. Ketamine was a big deal for us. We talked with another Batten family that was able to get it, and they had helped us. Our doctor was willing to talk to their doctor and have that collaborative effort. And our doctor, our psychiatrist, was willing to do the research and help us get it. And we went from not being able to even go out into public, let alone like a big family gathering, to then being able to have Christmas at my parents' house within a month of each other, a month of starting ketamine to being able to do that. And we started ketamine in November. There is no way we would have been able to do Christmas with my family, which is a big family, that year without ketamine. Absolutely not. So since then, we went from using Ativan, which is a rescue med for behavior, like 3 to 5 times a week, to almost nothing. Her angry outbursts declined. And you can see, like, as of now, we're reducing, and it's actually even lower starting next week. So that's her story. And we'll just see, but it's really nice to have a team that supports all of that. So thank you.
Thank you so much, Beth. Like I said, that's the expert, right? So it really is, I think, Beth and John as parents, and all of you guys as parents who will see these cognitive markers changing over the years and observe the behaviors. It's then really to us as your medical team to support you, to come up with a care plan, whether it's therapeutic therapies or medicines, et cetera, to make life as easy as possible for you and your kiddos. I want to now introduce Dr. Scherr from Nationwide Children's Hospital, who's going to speak a bit more with us about specifically behavioral implications of Batten.
Thank you. So our team is going to focus on behavior. I'm going to go back a slide here. Go back. Okay, so I'm going to be talking more about ABA and talking more about what it entails and how do you get it and some of those details. We have Bekah on the line, who's going to start by talking about some of her experiences and her journey in ABA. And then Dr. Albright is going to talk more specifically about behavior strategies that we recommend through our clinic and clinically. I'm going to try to go ahead here. Maybe. Top green button. Okay, so I'm going to start off by just some pictures of Eli. So the one on the left is Eli, myself, and Dr. Emily, and this was such a fun day with him. I think this might have been the day we ran through sprinklers at your house. And then
yeah.
some of the other pictures are recently celebrating his 11th birthday with some friends. So I'm going to hand it over to Bekah here to share some of her experiences and her story.
Thank you. Hello, everyone. Wish I was there in person to see all of our Batten family. Can you guys hear me okay, Jess? We're good. Okay, great. Well, the Zoom froze when Dr. Emily started to introduce me, so I'm not sure what all was shared, so I apologize if any of this is repeated, but our Batten journey started in spring of 2015 when our oldest son, Titus, was diagnosed. He was almost 5, diagnosed with CLN2. And we had Eli, who was not quite 2 years old yet, but we found out because, we knew it was genetic. We went ahead and got him tested and found out a few months later that he also had CLN2. At that time, there was not, Bernura was not accessible. It was in its phase 1 trial, and the disease really progressed quickly through Titus. And we did have to say goodbye to him for now when he was 6 in 2016. And literally 10 days after Titus passed away, we hopped on an airplane and flew to Columbus, Ohio to go see the Nationwide team to get Eli in for the extended compassionate use leg of the Bernura trial and begin infusions. He was 3 years and 3 months old when he began infusions. So his story has looked significantly different than his brothers. And so I'm going to jump in. I'm going to fast forward a few years to when Eli was about 6 years old is when we really saw like pretty much all of his vision was gone at that point. And we were having, Eli has always been a pretty easygoing kid, but we were starting to have some pretty extreme behaviors for him between 6 and 7 years old. And it was starting to impact every single part of his and our life. Things that he used to love. We used to do hippotherapy, which is physical therapy on a horse. We used to do water therapy, things like that he loved, but he started to just struggle, and he would be screaming and throwing his body and just in very unsafe ways. We could not keep him safe. We couldn't go out to eat anymore. We had car rides, 5-minute car rides to the school were a nightmare. We finally got an adaptive car seat, but he was escaping out of his car seat and trying to climb in my lap while I'm driving. So just freaking out. School was getting really hard. We couldn't leave him with anybody because he would just scream and kick, and it was just having a really, really rough time. And I think it was one of our appointments with Dr. Emily over Zoom. And she's kind of watching this and going, have you ever considered ABA? And my first thought was, oh no, that's for kids with autism. Like, we don't have autism, so I didn't even think about it. And it was eye-opening for me as I started to explore. We actually got really lucky. There's quite a wait list here in Idaho for ABA therapy, and we happened to find a person who was just newly going out on her own, leaving the previous organization she was with and going out on her own. So she had room on her client list, and we got started right away. And I will tell you that the start of ABA was really hard. And we started in July of 2021, just before Eli was going into 2nd grade, I believe. And I remember from July to November, I was second guessing myself pretty much the whole time because Eli was pushing back really hard. Sessions were full of screaming and anger. And I had to keep stepping back and going, but hold on, like, this is just the way it is anyway. So it's not like it's getting worse. I'm just feeling more anxiety about it because I feel like this should be fixing it. And it wasn't as quickly as I had hoped. But after those first few months passed, Eli started to fall into this rhythm with his therapist. He got a guy who is just awesome with him. He has gotten to know Eli's little nuances so well. He can tell like what his triggers are and how far to push and when to step back. But I want to make this really practical for you guys so you can understand the benefit that it has been for us. What I've appreciated about ABA therapy is, one, that it's been in our home. When it's at home, I feel like those skills that he learns transfers so much easier across his world. So when we go into a clinic and we're learning something, we come home, it just doesn't transfer quite the same way that it does with ABA therapy. We do ABA therapy twice a week for 2 hours each time. So my other what I used to think of ABA therapy was like a 40-hour, basically somebody following my child around and kind of correcting behavior all day long. These were very focused hours where they ran several trials, helping Eli with repetition, know how to cope and how to handle something and how to do something. And then it's been flexible. It's so flexible. So as Beth was sharing, our kids are changing, and even with the IEP comment, we're constantly having to come back and reevaluate. Is this a realistic goal? Is this goal actually helping Eli function well or do what he needs to do well? And ditching the goal if it's not, or reframing the expectations, or putting more supports around him so he can be successful. And so the goals that we started working on, just to give you an idea of like what we even did, we started working on using words and pairing them with signs to help him ask for more, for help, to say like all done, or I need a break, or go was one, because we'd get on the swing and go 1, 2, 3, go, and he'd give us the command to go to push him. So we started practicing those, and he is 11 years old now, just turned 11 on July 6th. And I'll tell you, he's still using those pretty proficiently. He's very communicative in that he can tell us when he's all done, when he wants something, when he needs help, when he wants more of something. So it's pretty awesome to see that carry through. We recently, with this kind of communication skill, we've incorporated buttons. And so we've just got 2 of those standard big buttons. I put like one of those felt pads that you put on the bottom of a chair so you don't scrape the floor. I put one of those on top of one of the buttons. So we have a yes button and we have a no button. He can feel the difference between the 2, and he's able to answer some yes and no questions, and he's doing really well with that goal. Some of the other things that we've done, he's had like a lot of our kids, he's very sensitive to things. So nail trimming, haircuts, certain clothes, shoes, like all of those things are kind of a problem for Eli. So we started working on a goal of nail trimming. And I mean, we started as little as you take the nail clipper and you just like set it on top of his finger for like 3 seconds, just so he starts to feel it. You know, we worked up from that to now we can sit down and clip all 5 finger, all 10. He has 10 fingers in one sitting without any kind of issue. I used to say it was like riding a bucking bronco, like trying to clip one nail. So it was huge. We're also successfully able to make it through a haircut now, which is amazing. So these are the kinds of things we've been working on, and it hasn't been overnight, but it has been a progressive improvement as we go. Some other things we had, Eli's mobility is changing. He can't walk anymore. And so sometimes we'll stand him up to try to move him into his chair, and he just drops his weight. He's getting big, he's heavy. It's a lot for some of his caretakers, my grandparents especially, to handle that. And so we've been working on things like wait, stand up, sit down, turn around, some of those. So he just knows what we're doing and how he can participate and help us with that. And then one of the biggest wins that I want to share with you guys is that Eli's because since he lost his vision, sound is really a big deal to him. And he can get overwhelmed quickly by certain kinds of pitches and noises, like little kid voices are really, really hard for him. And he has cousins and they're all younger than him. So they'd come over and Eli would just lose it. We'd have to remove them. We couldn't even be in the same room together. Family gatherings were really, really hard. And so our therapist said, let's have play dates. Bring little cousin JJ over, and we'll have them play in the same room for 1 minute, and then we'll have JJ go away, and then we'll bring him back again, and we'll just keep working on it. And I'm excited to tell you that now we can have full-on family gatherings. We spent like 8 hours the other day with family for 4th of July, and Eli just did awesome. So it has increased his ability to handle, to tolerate the noises that originally were really, really hard on him. And I will just say that for me, I know ABA, I've heard it from other special needs families here in Idaho, that ABA has kind of a bad rep. They think it's just kind of training our kids to be robots, like obeying commands and trying to fix their behavior. For me, ABA hasn't been about behavior training. It's really been about building a platform for Eli to get through life successfully. I always tell people to help them understand who Eli is. He's like a bucket. He's got this bucket, and when he wakes up in the morning, if he's already overwhelmed, his bucket's full. And if we try to put anything else in that bucket, it's just going to overflow. It's not going to work, and there's no room. So ABA for us has been about how to help empty that bucket. So as things are put in, he can handle that better. So I hope that helps. I hope just some of those like little, just so you can see the flexibility of the therapy and how we've been able to adapt it to whatever his needs are, so he can function and be happy and be part of the family in a way that is really fulfilling for all of us. So anyway, Jess, I'll pass it back to you.
Oh, Thank you so much, Bekah. That was beautiful. And I really loved some of your examples and descriptions. And thank you for sharing kind of your journey with ABA, with Eli, and kind of highlighting too. I think a really important thing you said is a lot of times people think of behavior management as kind of the key like purpose of ABA, but it really is teaching functional skills, teaching adaptive skills, maintaining skills. And I'll talk about that in just a little bit. So thank you, Bekah. Just a few acknowledgements. A big thank you to BioMarin, who has funded our research, and some of our sponsors. Oh, they are going nuts. I'm not sure. I don't know why they're on a loop. Sorry about that. Yeah. Okay. Oh no. I wish I knew some funny jokes or something, and this sound. You do not want me singing. So, thank you for your patience. Yeah, I guess I can just keep talking while we get the slides going. So acknowledgements, big thank you to BioMarin for sponsoring our research, and then some of our other sponsors. Another thing I wanted to highlight too, we've started to look at behavior in CLN2, and we have found that particularly in younger kids with CLN2, there's increased risk for behavior problems, attention difficulties, social difficulties, aggression, and also potentially a higher risk for autism as well. We're seeing kind of autism symptoms and features in CLN2. In children that have a comorbid diagnosis of autism and CLN2, we're also seeing more behavioral difficulties in that group. There is a critical need to gain a better understanding of how behavior symptoms change over time. I see slides are up, so I'm gonna go forward a few slides. And that behavior intervention can really help. Okay, so what is ABA therapy? So again, kind of two main goals in ABA therapy. So one is increasing or teaching skills that are helpful or useful or functional, and then also reducing behavioral challenges. And ABA therapy, it stands for Applied Behavior Analysis, and it's a therapy that's really based on science of learning and behavior. Some examples of programs and what they can work on. So it can work to improve or increase language and communication skills, attention, focus, memory, social skills, and adaptive skills, so skills of daily living. Also to work to reduce or decrease challenging or disruptive behavior, tantrums, meltdowns, aggression, and defiance or noncompliance. I really like kind of the tenet of ABA therapy where one size does not fit all. Bekah highlighted really beautifully kind of how, a good behavior program will individualize their treatment to the person or the family. So ABA is flexible, it's individualized. It can be provided in a lot of different locations, and I'll talk about that in just a second. And it really focuses on skills that are useful in everyday life, that are important to the family or important to the individual, and with a focus to improve that quality of life. So how does the ABA therapy work? So usually the person in charge, the captain of the ship, is a trained and qualified board certified behavior analyst or a BCBA. And usually you have a team around you with different therapists. And the BCBA really leads and kind of oversees that team or that treatment. They individualize the treatment plan, the goals of what you're working on to the person and the family based on needs, skills, interests, and kind of what the family's preference is of what do we want to work on in this moment, in this time period. And they really create specific treatment goals. And one kind of unique thing about ABA therapy is that they track and kind of monitor progress over time to see, are we making progress toward that goal? Do we need to shift things? So it really is individualized and data-driven. So these are just some examples of possible treatment goals. So again, communication and language, self-care, play and leisure, motor skills, or learning and academic skills. And it's really based on kind of the skill set of that individual. There are different settings that you can get ABA therapy. So again, as Bekah kind of highlighted, therapists can come into the home and work with the person or the family. There are also center-based ABA centers that look a lot like school. So they're very similar to school. There are peers, there's other students there. And then there are parent training models where you, a parent, can learn some of the strategies for ABA and work with your child. So there are parent training groups, or there are individual parent training kind of options too. So how to find ABA therapy? So first step would be to check with your insurance company to see if they cover the cost of ABA and what your benefit is. I know every state is different in terms of coverage. Schedule an appointment with your pediatrician or other medical provider or medical team to talk about options for ABA. They might be able to advocate by writing a letter or a prescription for ABA, again, kind of dependent on your state. Or search for different ABA providers that are in your area. You can ask your doctors or teachers for those recommendations, or you can do your own search and contact an ABA provider and request an intake evaluation or to talk with somebody to get more information, or even to take a tour of their center to see kind of what it looks like and what services they offer. These are some other evidence-based behavior therapies that are common. So again, we talked a little bit about parent training, behavioral consultation. PCIT is parent-child interaction therapy. So that's where you're coached in the moment to handle kind of challenging behaviors, cognitive behavior therapy, and then also family therapy. I wanted to highlight, this is an article that is going to be hot off the press. By Annika and other authors. And I thought this tied really nicely into our talk. So I wanted to take a few seconds to kind of highlight this. So this is a case report that really highlighted kind of plans and behaviors and behavior management in two females in their 20s that had CLN3, Batten disease, and Sanfilippo syndrome. And they really focused on how to reduce kind of two behaviors, aggression and irritability. And they use person-centered, so again, very individualized kind of interventions that were behaviorally based. And this was through Dementia Support Australia. And their kind of aim was to improve physical and psychological well-being, cognitive functioning, interpersonal relationships, behavior, and overall quality of life. Some of the behavioral interventions and therapeutic interventions that they highlighted, and they did a really beautiful job kind of highlighting each of the case studies and how they utilize these to improve different areas. So reducing overstimulation, establishing routine, sensory engagement, different communication techniques. I really like the 5S communication technique that was highlighted. So when you're giving a communication direction, you want to smile, show, be simple, very specific, and also show to help with communication. Personal care, pain management, and distraction techniques, and then just kind of family caregiver support. I'm going to pause here and hand it over to Dr. Albright. Thank you for your time.
All right, and so I want to finish this part of the talk, and I want to try and do it kind of quickly because I want to make sure that we have time for any questions and answers and further conversation with the broader group. But I want to talk a little more about some of the specific behavior strategies and put in a couple plugs for this idea of what we call parent training or parent mediated interventions. And the big thing for parent mediated interventions, why they're really helpful, is that you all are the experts of your children. And you are the people at the end of the day who are with them the most. So the reason why it works so well is regardless of the ABA therapies working with your child, regardless of the teachers working with your child, one, you'll be there and be part of the people practicing and working more than anybody. And two, you'll also be the people who are advocating, who are there at school, there with therapists, working through some of those ideas. And so the more you all can learn, and you already know, I'm always amazed at this conference, the level of expertise every parent has, the understanding of biochemistry, the understanding of behavior, that it's amazing. And so the more we can understand these concepts and then apply them, the better we work. Because of two things. One, everything, you hear it over and over again, the word individual or individualized. And so we're always adjusting, we're always thinking, we're always changing with Batten's and with a lot of different disorders. And thinking how we manage behavior, that's going to change, and we need to be able to kind of change with it. And the second one is a secret that most of the behavior experts don't want you to know, is that moment, that behavior that you either want your child to do less of or do more of, when they're banging their head where they won't take another step, and you have no idea what to do or how to change that behavior. The secret is we don't either. Families come to me almost every week and have one of those situations, and I go, boy, I don't know. But the reason I have confidence is I think I know how to figure it out. And that's what a lot of these principles of ABA do for us, is it gives us a process, a way to figure things out. And these are things that you guys are doing every day already. And so it's not necessarily always even changing things or doing something you've never done before, but learning and understanding the whys of what you're doing already. So a couple of ideas that we want to think about when we're thinking about ABA, behavior management, any of these things. Behaviors are often learned. What we do today is likely what we do tomorrow. That's not anyone's fault. It's not, just because someone has started screaming every time their laptop dies or throws it when it doesn't work. I may have done that before. Doesn't mean that, someone else caused it or someone else had the problem. But what you did before is likely what you're going to do next time. And behavior is often a form of communication. There are things that we want or we need, and the things that we do communicate those wants and needs. Another thing, especially when you're talking with behaviorists, that's helpful to think about, behavior is anything that we do. We often talk about behaviors the bad stuff. It's the spitting, it's the cussing, it's the hitting. But when you talk to someone like myself or Jesse or other behaviorally focused psychologists or behavior analysts, any movements, me leaning forward is a behavior, leaning backwards behavior, me speaking is a behavior. So it's everything that we do. And there are things that we do that can be counted, timed, and observed. So, we talked very nicely about the way you kind of change your thinking a little bit when you're thinking behaviorally. And you're thinking about the things that you can observe, things you can count, the things that you can time. How many times did they throw their iPad down? How long were they screaming for? That doesn't take away everything else we're thinking about. It's not trying to think of forget about everything else that's happening, but it's a way of thinking that helps manage us to kind of manage some of these behaviors. And another thing that we often think about reacting once the behavior's happened. We're in the middle of a meltdown, and how do we stop it? And what many of you have likely already learned is once you're in that moment, there isn't much else you can do except make sure everyone's safe and make sure it lasts as short of a time as possible. And the people who are really, really, really good at this, they do more and more thinking about what will happen and managing things before they happen, because there is nothing magic that changes it once it's happening. If there was, we would be very excited, but just not the case, unfortunately. And so we talked about functional behavior assessment. Functional behavior assessment is the way that schools use behavioral principles to understand how to affect behavior at school. ABA just did a beautiful job highlighting what ABA therapy is. And all of it comes down, I'm talking about parent-mediated interventions. All of it comes down to this right here. So we call a 3-term contingency. So the ABC model. Antecedent, behavior, consequence. And just a couple things to think about with the A, B, and the C. An antecedent, you've heard people probably use the word trigger. An antecedent is the trigger to a behavior. But it's not necessarily just the thing that we think it could be. It's just literally whatever happens right before the behavior happens. It didn't even necessarily cause it, but it's what happened right before. Similarly, the consequence to the behavior is whatever happened afterward. That may not just be the thing that we decide to do. So you hear a lot, the consequence is that they're not going to get their cookies. It's not just that, but it's literally what happened right afterwards. And the reason why this is the core for everything is we know the more that we think about what's leading up to a behavior and what happens after the behavior, we can think about how we can change those things in order to change the behavior over time. So a real quick example that's probably, familiar to many, a child's watching their iPad, they're watching a show. The iPad dies. The child starts screaming, maybe throws the iPad. So we have an antecedent. The iPad dies. We have a behavior. Child throws it. The parents very on top of it. They said, seen this happen before, so we always charge a second iPad for when the first one dies. The first iPad dies, they immediately give them a second iPad. So you see there a chain of behavior. Something happens, behavior happens, consequence happens. You'd also probably start to think of ideas of what could change that behavior. And that's the way we think about changing behaviors over time. So a couple things that when we're thinking about the ABC model, it's hard to figure out the why of why the behavior is happening. So that separation, that analysis, that breaking things down is what makes it easier for us. It also is hard to do on any one individual child behavior. When you see something just once, it's hard to just know what's happening. That's why that's that secret, right? That we just don't know. But when you start to track it over time, when you start to look at it over time, you start to be able to recognize how we may be able to affect things over time. And that allows us to make decisions about these behaviors and create hypotheses, because it's not then, once you've decided, that you'll just know, but we can try an intervention and see how it's working. And again, like many things, we want to think about the communication of what the behavior is communicating, and how we can think about we can meet those needs in other ways. So a couple of things. Prevention strategies. Prevention strategies are the strategies that we use to affect the antecedent of the behavior, the things that are happening before the behavior occurs. And just for the sake of time, I want to move right to them. These are some of the ones that we often think about. And one of the things I always highlight in this, these are things that you all as parents are doing. You may avoid a situation. Every time we walk by the candy aisle at the store, we start screaming because we want some candy. Maybe the strategy is to not walk by the candy aisle. You can control the environment. We can move where things are. One of the favorite ones that we often do is thinking about things in small doses. This is, if the grocery store is where meltdowns tend to happen, and we're doing our Saturday shopping and it takes an hour, we may want to think about, do we do that? Do we not bring the child for those long Saturday grocery store trips? Do we start by just running in and getting some milk and running out 5 minutes? And then, as we heard beautifully in some of the examples earlier, then 5 minutes can become 6 minutes, 6 minutes become 7. And that's the way you build towards some of these things over time. We can change how we ask. The classic of this is we know that sometimes the word no right there leads to a meltdown. Sometimes just changing how you ask can affect some of those things. Oh, you'll see some other ones here. Just for the sake of time, I'm not going to touch on every one. Another one that I just want to make sure we see there is what we call setting events. Setting events are the things that set the stage for a behavior. If you haven't slept the night before, more likely to have behavior. If you're real hungry, some of you guys are maybe less interested in me talking than you were an hour ago because we're getting close to lunch. And so you may be now getting a little more like, all right, gotta get over it. I gotta go get lunch. Setting events are something we always want to think about because they're some of the more far away things that affect that behavior chain that we talked about earlier. And then reinforcement. Reinforcement's at the core of so much of what we do with behavior analysis. And it's anything that increases the likelihood of the behavior happening in the future. And that increase is really important because it's not just the things that we say. Well, an M&M is going to be reinforcing. A high five is going to be reinforcing. A good job is going to be reinforcing. But for a lot of our kids, they have idiosyncratic things that they like. And so thinking about how we use reinforcers, the things that follow the behavior, the consequence of that behavior, that increase the likelihood of those behaviors happening in the future, the more we can think about how we can say, hey, this is a good way to get that want and need met, and that other way isn't going to be as much. So reinforcement is going to be at the core of everything that we do. And so the last thing I want to talk about is a really important one that is often the case when we started with talking about cognition, thinking about learning. Whenever it's harder to communicate for someone, and usually oftentimes that means expressive language, right? Your ability to get what you need out. That's often where behavior, disruptive behaviors, meltdowns, frustrating behaviors, however you call them, that's often where they occur. And so for a lot of our kids, we know definitionally that communication is going to be a challenge. So there's strategies we use called functional communication strategies. You may call functional communication training. The idea of it is to think about what we're asking. Again, the behavior is communicating something. And can we teach another way to meet that same need? So again, if we went back to the child, the iPad has died, they throw it away. And then the parent brings another one. So if we instead we see the iPad's about to die, so maybe we get a hand on it so we can't just throw it, and we help them tap twice. And once they tap twice, now they get the iPad. What we've done there is we've changed the communication, right? The communication before was iPad's died, throwing it. We're going to practice instead tap twice. And that is a way to change the ask. And instead of reinforcing the throw, the new iPad, we're reinforcing something else. It doesn't happen the first time, but if you do that and practice that over time, like in our beautiful examples before, that can change because everything we're doing is learning and everything we're doing is practicing. And so when we start to change what we do in a situation, that's how over time, that becomes what we do. So functional communication is something that's really helpful. All of these things are things that behavior therapists in your area could likely work on. Obviously, this is a very, very specialized population. This is very, very specialized situations. So we are always happy to talk with other providers, talk with other experts to help educate and to help create context that'll make everyone successful. And so just to finish off a quick picture of our team at Children's and everyone there doing such hard work for our families. So I'll stop there and we'll open up for any questions. I'm okay to stand if you any questions, things people are wondering about? Yeah. Oh, yeah.
You have a second.
First, am I on? Am I on? Oh, there I am. I just want to thank you all so much for the really practical information that you presented this morning. I really, really appreciate it. My question has to do with supporting our schools and teachers. And so we're fortunate to live in a very supportive school corporation and especially a very supportive school itself, but they don't know Batten. And so I'm just wondering if there are any resources that you could point us to, that we could point our teachers to, that they could learn from kind of in the immediate future.
I think, this is going to be bad if I'm wrong, but I think the BDSRA has like a support like link. And then, you know, just right on the BDSA website. And then it's like for schools. And then like there's kind of handouts that are already created.
We have
But
a Teach the Teacher
Mhm.
document that's quite historical, let's say. But
I knew it was
we-
there.
Yeah. And we want to update that as well. And the other resource that I always recommend to families is the textbook that you've referred to as well. Although it's CLN3 focused, I think it definitely applies to all of the subtypes when it comes to that, cognitive decline and looking at the supports on the background of regression. The name of the textbook is the JNCL. So in Scandinavia, they refer to it still as juvenile NCL commonly, but it's all about education. And there's actually a copy of it floating around near our registration desk or on one of our desks where our resources are. Highly recommend it. And we actually provide a free copy to all families. It's a big volume, but we will post that out to you. And it's also fully downloadable online as a PDF, which you can share with your supports. It's all free. You can share with your schools, supports, anybody really. It's written intentionally to be a very practical, accessible guide. It's not super technical, but you will see every name you've ever associated with Batten disease research, care and treatment is pretty much involved in there across the world as well. It's got quite an authorship list.
One thing we did several years ago was I started a spreadsheet, because that's how my brain works, with just a synopsis of the disease, the girls' names, and then I went through, you know, when you go to the doctor and they ask you like head to toe, what in behavior, all that, and toileting, I did a chart and like update it every year so that when we go into a new school year, I can send that to their whole team so they can go, oh, she needs to brush her teeth. We're working on brushing your teeth at lunch, or she needs cueing every 2 hours to go to the bathroom. And cognitively, she's 3 and not 15, just to give a snapshot along with a link to that textbook.
And Beth, I love that example and I love that idea because I think there's two sides to helping teachers in these situations. And one is giving them the new information they don't have. But I think the second side that goes with it that I think is often important too, is most of us, when we don't know something, we go, that means I can't do anything. And so I think like you're showing is just because you don't know about my child's condition doesn't mean you don't know my child, doesn't mean that you don't know children, you know? And so we also want to help new professionals see what is the same. These principles of behavior, they are the same. And there are going to be things we need to do that are different, but we can start today on some of these things that have worked in the past, and we can build on that as you build knowledge. Because sometimes schools especially, they go, oh, well, let me learn about that, and we'll know about it in about 3 years, and then we could talk to you. And as we all know, we just don't have that time. Any other questions? Yeah. Yes.
One more thing that I meant to say earlier is I wish we had started ABA sooner. So if there's any younger sealant or two families in here, I wish we would have known about it at diagnosis when things were still, quote, good, because the cognition was so much higher. And they would have been able to learn more tools, and we would have been able to learn more tools and change those triggers and change that ABC pattern. And I think it would have saved maybe some scars on my body potentially. So, yeah.
Well, I think that pretty well wraps up our time for this morning. Now, nearly this afternoon. So we're coming in for a lunch break at 12 o'clock in next door. I would really like to say thank you to Bekah online. Thank you so much. You're always wonderful speaker.
It was great being here with you all for just a little bit. Thanks for letting me be part of it.
No, it's a great pleasure. And thank you very much to all of our speakers today. And thank you for making yourself available throughout the course of the weekend if there are any more questions.